Hi, everyone. Thanks for joining us at today's Research to Practice webinar hosted by the Suicide Prevention Resource Center Training Institute at the Education Development Center. Please note that your phone line will be muted during this entire webinar because we have a large number of people participating in the event. We welcome your questions throughout the presentation and will be responding to a selection of them during the Q&A section at the end. Please note that we won't have time to respond to everyone's questions, but we'll do our best to get some of the major themes which come up. And again, for those of you who just joined us, welcome to today's Research to Practice webinar hosted by the SPRC Training Institute. The title of this webinar is Emergency Departments, a Key Setting for Suicide Prevention. And clearly the topic of today's webinar has generated a great deal of interest, so welcome to you all. My name is Lisa Kaposha, and I'm the Assistant Manager of Clinical Initiatives at the Suicide Prevention Resource Center, and I'll be moderating today's webinar. Our presenters today are Dr. Marion or Emmy Betts, Dr. Leslie Zunn, Dr. Michael Allen, and Dr. Edwin Boudreau. I'll be introducing them in a bit. With close to 500,000 patients visiting emergency departments for self-inflicted injuries each year, emergency departments have a critical role to play in preventing suicide. And at the same time, we know emergency departments face challenges addressing the needs of suicidal patients due to the fast-paced environment, the complex nature of suicide, and barriers to accessing follow-up care. In today's webinar, you'll hear from experts in emergency medicine, emergency psychiatry, and research. They'll describe the rationale for ED-focused suicide prevention, and we'll discuss barriers and solutions to integrating suicide prevention in EDs. You'll also hear about a new resource titled Caring for Adult Patients with Suicide Risk, a consensus guide for emergency departments. The ED guide was developed by SPRC with funding from SAMHSA and in collaboration with a large panel of multidisciplinary experts. Today's speakers played key advisory roles in that effort alongside representatives from emergency nursing, people with lived experience, and others. You'll hear more about this resource later in the webinar. I'd like to introduce our first speaker, Dr. Emmy Betts. Dr. Betts is a board-certified emergency physician and clinician at the University of Colorado Hospital Emergency Department. She's an assistant professor of emergency medicine at the University of Colorado School of Medicine and an assistant professor of epidemiology at the Colorado School of Public Health. Dr. Betts will review research on the current state of suicide care in emergency departments and will highlight key areas in which to integrate suicide prevention strategies. Welcome, Emmy.
Great, thanks. I'm very excited to be here and get things started. By way of very brief introduction, emergency medicine is a unique specialty, and we really pride ourselves on dealing with unforeseen illness and injury, acute issues as they arise. We treat patients regardless of demographics or ability to pay, and therefore really function as a safety net in the United States. We also have a particular focus on short-term morbidity and mortality. And it's important to remember that when you think about the larger conceptual framework of how emergency departments function within the larger healthcare setting. Patients come to us from a number of settings. They may be referred from outpatient medical settings, outpatient mental health settings. They may call some kind of hotline or advice line and be sent in. And they can come either via EMS and ambulance, or they may show up on their own by some other method of transportation. After emergency department care, they then typically go to one of a few places. They could be hospitalized in an inpatient setting, either medical or psychiatric, or they might be discharged home with referral back to the same kinds of outpatient settings. I think it's important for us to acknowledge the flow that's evident in this diagram as we think about emergency department care. We ED providers often have a big focus on what we call disposition, which is where's the person going. And that's because we have to keep things moving so that we can have beds open for the next patients coming in. It's also certainly better for the patients to have the most timely and efficient care that they can rather than waiting extra hours in the department. Typically, a patient in the emergency department would be assessed and cared for by a nurse and then an ED physician or some other provider like a physician assistant. This is true for both suicidal patients and patients with other complaints. Emergency medicine has its own residency after medical school and its own board certification. Typically, an ED physician will see somewhere in the range of 15 to 40 patients on an 8-hour shift. And I think we really pride ourselves on being able to multitask. We care for multiple people at once with a breadth of issues. And I think we also pride ourselves on being able to really triage patients in terms of understanding what it is that they need today, what it is that they can get in sort of urgent follow-up. And so we call consultants as needed. But again, there's often this focus on disposition in terms of getting people to the next setting of care that they might need. Shown here are the top 10 reasons for ED visits in 2010. And I show this really just to, to highlight that mental health complaints actually are not on this list, although they certainly contribute to some of these reasons. And if you look at total ED visits, you can see that only a small percentage have a mental disorder diagnosis or consultation by a mental health provider or a psych hospitalization. I certainly don't show this to minimize the importance of these issues, but rather to highlight that EDs deal with, again, a breadth of problems, and I think we need to understand that when we work with them in terms of improving care of suicidal patients. And we know that visits for mental health reasons, though, are rising, and we also know that about 40% of suicide decedents are seen in an ED in the year before death. So I do think that we can really make the case that emergency departments are a key setting for identification and care of suicidal patients. And that's why it's very exciting to have the new SPRC guide to help inform some of those efforts. In terms of identification of patients, many do come in with a psychiatric reason for visit. They may bring themselves in or be brought in by a concerned family member or other party. But we should also acknowledge that there may be a large proportion of patients who have so-called occult suicidal thoughts or behaviors, and that they may not disclose unless asked. There are various methods of screening for patients. I don't have time to go into these in great detail today, but just briefly, indicated screening would be when an ED provider asks the patient about suicidality based on the patient's physical exam or complaints. So if the patient is tearful, has a flat affect, etc. Selective screening would involve screening all patients within a high-risk subgroup, like all patients with alcohol abuse. And universal screening would be universal in that it would imply screening of everyone. I do want to point out that probably either selective or universal screening would fulfill the Joint Commission requirement for National Patient Safety Goal number 15, which is to identify patients at risk for suicide, and that applies to patients being treated for emotional or behavioral disorders in EDs. We don't have time to discuss this in detail today, but it's worth knowing about because it is a requirement for that hospitals have to comply with, and so it can help frame the care of suicidal patients. Today I'm going to be presenting some data from the ED SAFE study, which was a large NIMH-funded trial that's now completed. It was at 8 emergency departments across the country, and it was a complex multi-part study, but here's a rough schematic of what was involved. The larger study aimed to really look at the concept of universal screening as well as telephone counseling in a cohort of patients. And as you can see, in phase 1, it was treatment as usual, and then phase 2 was when universal suicide screening was introduced at all sites. So all the participating sites started screening every ED patient for suicide. And this is the safety screener that was used in ED SAFE. So 3 questions that were asked by the primary nurse, so not the triage nurse, which is typically the person who greets the patient, but rather the primary nurse, who's the main nurse who then will be taking care of the patient during the visit. And in most places, this was included with other kinds of screening, like domestic violence screening. As you can see, it's a 3-question screener. It was quick and easy and embedded in the medical record. And some of the analyses are still ongoing, but basically the rate of detected suicidal thoughts within the past 2 weeks doubled after universal screening was implemented. So yes, if we start screening everyone, we certainly will identify more. We certainly are missing people. I think the questions of how we best use resources those are complex questions, certainly meriting further discussion. But I'd like to talk a bit about sort of typical care, since I realize that many of you may not be familiar with ED processes. Once a patient is recognized as having suicidal thoughts, recent self-harm behaviors, or some other risk of suicide, typically the ED would do some kind of questioning. I want to point out that this is not typically a focused assessment or structured assessment, but it would be questioning based on that ED physician's prior training. And then if the physician is concerned, he or she would typically consult a mental health professional, and that might be someone from on-site, like a psychiatrist, psychologist, social worker, who might be available 24/7 or perhaps only limited hours. Or it could be an off-site team that has a contract with the ED to come do in-house evaluation. So the team would come see the patient in the emergency department. Some EDs also use a combination of these two systems depending on the insurance of the patient and where the patient lives. And the schematic on the right, I think, shows the way many ED providers traditionally have thought about care of suicidal patients, which is really this idea that if someone is suicidal, then the care is kind of handed over to the psychiatric, the mental health team. And many ED providers may have traditionally seen their role as really providing medical clearance, addressing any acute medical issues, but not really doing any kind of additional risk assessment, and instead handing that over to the mental health team. The problem with that is that we know we have limited inpatient beds, limited outpatient resources. These contribute to very long, sometimes days-long waits for suicidal patients in the emergency departments, for the people who need an inpatient hospitalization. Limited mental health professional availability can also cause problems. For example, rural or smaller hospitals that are calling in off-site teams might have to wait hours for that consultant to show up, which isn't good for patient care and certainly isn't good for the overall flow of the department, as I mentioned earlier. And then if you add on the issues of ED crowding and large volumes of patients in general, all of these things really add to provider frustration. But I think they also offer great opportunity to really engage providers in taking on some of these skills themselves. And when I talk with ED providers, I often use the analogy of chest pain. I think we as ED physicians really pride ourselves on being able to read EKGs and do an initial risk assessment of a patient with chest pain. And we certainly don't call cardiology on every patient with chest pain. We certainly don't admit every patient or do extensive testing. And we have clear guidelines, and I think really have taken ownership of this area in a way that we haven't in the past for suicidal patients. And I certainly think that the input of mental health consultants is invaluable in many cases, but for some of the patients who are perhaps at lowest imminent risk, I think ED providers could be doing more themselves, and the hope is that this guide may provide a framework for that. And I'll just mention that current assessment options that may be in use include things like modified SAD persons, the Manchester self-harm rule, and the short version of the CSSRS. And I'll just say that really none of these is ideal for use in busy EDs in the U.S., either because of how they were developed and validated or because of the particular patient populations that they apply to. So now I'd like to finish up with looking at a little bit about what we know about ED providers and their self-reported beliefs, behaviors. I think that understanding the provider attitudes and current practices is important as we try to improve things. So in the ED Safe study, we did surveys at 3 points. Surveys were administered to all of the nurses and physicians at the participating 8 sites. We had an excellent response rate, slightly over half women, about 2/3 nurses, the rest were physicians. And a couple of just overall points. The survey respondents cared for a median of 15 suicidal patients per month. So this is, I would say, a pretty common thing that they're seeing. But slightly less than half said that they thought most or all suicides are preventable, which I think reflects probably a combination of both skepticism or bias as well as inadequate training in suicide prevention. So the next couple of slides show some of the domains we asked about. This first one is physician and nurse self-confidence in skills, some basic skills related to care of suicidal patients. What you can see is that providers felt pretty good about their ability to screen patients for suicidality, but then really confidence in skills dropped off in terms of further risk assessment, providing counseling, and creating a personalized safety plan. And I think that's in part because some of these things have not traditionally fallen to the ED providers, as I mentioned, and have been sort of instead given over to the mental health providers. in terms of physician and nurse opinions of ED environment, we compared to phase 1 to phase 2. We saw some improvements in terms of feeling like leadership-supported interventions after universal screening was implemented. And then importantly, if you see that universal screening, an increasing proportion said that they thought it would result in increased psychiatric evaluations, but actually slightly decreased proportion thought it would slow down care. And this is really important, again, as we think about efficiency in the department and the idea that it may be feasible to introduce screening as long as it's done in a way that is consistent with the other resources in the department and has a clear plan of care. We also asked these nurses and physicians, well, what do you actually do? So not your confidence, but what kinds of skills do you, or what kinds of behaviors do you do with patients who are suicidal? And you can see before universal screening, a very low proportion said they screened most or all patients for suicidal ideation. And then for patients who were suicidal, really not great numbers in terms of who doing risk assessment or brief ED interventions. I do want to point out this is probably because for many of these patients, a mental health consultant was called in to do some of these, the risk assessment and safety plan and so forth. But then after introducing universal screening, you can see the proportion there in the dark blue bar really jumped up to almost 80%, with some very modest improvements in some of the other activities. And I'll just point out that we didn't do extensive training in terms of the other skills that were involved. Really, the training was focused on how to implement the basic screening. And then just to finish, I want to talk briefly about means restriction. We know that assessment and counseling about reducing access to lethal methods like firearms is a critical aspect of suicide prevention, including in emergency departments. So we asked people who they thought should be doing this. And what you can see here, this is nurses and physicians combined. Both really thought it was the job of psychiatrists, shown in the black bar, or some other mental health worker in gray, followed by an ED physician. I think the take-home on this is that the lowest proportions saw this as a job of nurses. And so if we're expecting nurses to be doing discharge planning and other kinds of safety counseling, we need to acknowledge what they've traditionally viewed their role as, and also what kinds of training they may have had or not had in the past. Also worth pointing out, it may very well be that this is a responsibility for the mental health consultants as well, but at each site it's important to make sure that someone at least is doing it so that it doesn't fall through the cracks. And then we also asked people about what they actually do in terms of when they actually ask about firearms. And I think two take-homes from this. These are all high-risk scenarios where I would argue that the ED providers really should be asking patients if they have access to firearms. And what you can see is that across the board, really, physicians were more likely than nurses to ask, which I think is consistent with really what we traditionally have seen as their roles. And then, well over 80% of physicians said they often or almost always ask if the patient has a gun at home, if the patient has a suicide plan with a gun. Really, I would say inadequate proportions of physicians said that they were asking about guns in these other high-risk scenarios. I think that gets to the idea that ED providers are often very task-focused and think of the scenario at hand, but also probably some inadequate training to date. And so just to sort of finish up and then turn it over to the next speaker, I think we have a lot of challenges but also really great opportunities right now in this field. I think there's still questions about who will do suicide screening as well as assessment. We need to acknowledge that there's a lot of variation in ED capability in terms of rural versus urban hospitals and small versus large, and it's important to acknowledge that as we introduce new guides. And also that we've had inadequate training. So new resources are fantastic, but they need to be accompanied with whatever training is needed by the providers. And I think there's some work to do in terms of at the level of residency and medical school, nursing school, and so forth. Then we certainly need better evidence-based tools, and I think the SPRC guide is going to fill some of these gaps. And I would be remiss if I didn't mention that we certainly need better access to both inpatient and outpatient mental health resources. And I think on that, I think I actually ended a little bit early, which is nice. We may have a little bit more time for questions, although I think that there may be a question before we move on to the next speaker.
Hi, Emmy. That's right. That was so helpful. Thank you. And we will be saving questions till the end, but there was one question that came in that I thought if you could answer it now, it would help the audience maybe with some of the other presentation topics. So the question was about the term occult suicidal ideation and what is meant by that.
Sure. I think that term has, the word occult, I think, was first applied to it. I'm not exactly, well, it's basically the idea that someone has ideation that they may not disclose unless specifically asked, so that it may be hidden unless there's some kind of specific screening or questioning about it.
Great. Thanks so much, and we'll have more questions at the end. I appreciate your talk. Thanks. So I'm going to now introduce Dr. Leslie Zunn, our second speaker. Dr. Zunn is the System Chair of the Department of Emergency Medicine at Sinai Health System in Chicago. He's also the Chairman and Professor in the Department of Emergency Medicine and has a secondary appointment in the Department of Psychiatry at the Rosalind Franklin University of Medicine and Science at Chicago Medical School. Dr. Zunn is also the course director for the National Update on Behavioral Emergencies Conference. And Dr. Zunn will address how to engage the emergency medicine sector, and he'll also discuss some of the barriers as well as solutions for integrating suicide prevention into their ED practice. Dr. Zunn?
Well, thank you, and welcome all to the next phase in the discussion. So the couple things that I want people to get out of this, or this portion of the webinar, is to, kind of take what Emmy had said and move it forward to continue to understand emergency medicine and some of the unique approaches or the unique way we provide care in the emergency department. Second is really to, how do we approach the emergency providers if we're not part of that gang of people, so to speak. And then third is how to determine or how to modify physician behavior in the emergency department. And again, I think that's a fairly unique way to look at things. So to expand a little bit about the history of emergency medicine, years ago, emergency medicine had quite a different approach where physicians were assigned to work in the emergency department from different specialties, and it was on a rotation. It was part of the requirement of being on staff at that hospital. You had to staff the emergency department, 1 or 2 or multiple days a week. Then there was some time when it was staffed by interns with little or no supervision. So I think we've come a long, long way from where we were at years ago, where it's really emergency physicians that are trained in emergency medicine staffing emergency departments. And in response to that, in 1968, there was the establishment of the first specialty organization, the American College of Emergency Physicians. Some years later, there was another organization. There's a few other ones. The other one is the American Academy of Emergency Medicine that was established in the 90s. And there's a board examination for emergency medicine. There's a written and oral component, as well as the requirement to be recertified every 10 years. It started in 1979 and became an independent specialty in 1988. So we look at the role of emergency medicine, really a couple things. Although we tend to think of ourselves as always dealing with emergent problems, always dealing with that cardiac arrest or that trauma, in reality we actually provide a significant amount of urgent care and even some non-urgent care, what I think we refer to as primary care, although most of us would agree that's probably not the best place for primary care. Unfortunately, for many reasons, patients use the emergency department as their primary care network. Second is we view ourselves as a coordinator of follow-up care. So we try to give the patient referrals or connect them with certain clinics or other resources that we think will best meet their needs. Many emergency departments are considered safety nets, where patients have nowhere else to go, especially in the era of unfunded patients could always go to an emergency department but may not be able to go to a primary care provider or have other resources to utilize. And the next kind of development in emergency medicine was in the managed care environment, where we were part of the gatekeeper function, where emergency departments would decide what would be appropriate follow-up, or who the patient could follow up, or whether they needed follow-up, or how we can coordinate with managed care. Now, we're going to probably see more and more of this, emergency department working in the managed care environment as we move to the ACO environment, where emergency departments are going to have to be all part of the population health and working on preventative and reduce readmissions and reduce ED visits, et cetera, et cetera. So the next question is, well, I'm a mental health worker, psychologist, psychiatrist, whatever, and I want to teach emergency physicians or emergency providers how to better deal with psychiatric patients, with suicidal patients, and how do I go about doing that? So there's a couple of different suggestions that I have. And so we're going to talk about how to engage emergency departments, and then also how do we engage the professional organizations both on a state and local level. And we're going to talk about what it means to offer solutions, and how do we build relationship with this group of professionals. So one of the barriers that we see a lot is that it's difficult to engage the emergency department sector, and I mean both emergency physicians and emergency nurses. And so one of the means to engage them, to educate, to inform, to bring up new ideas or new treatment plans is either to approach a state chapter of the American College of Emergency Physicians, and there's one in every state. The American Academy of Emergency Medicine has state and regional chapters. ENA, the Emergency Nursing Association, also has state and some local chapters, depending on the population involved. But for some, there's a way emergency physicians are staffed. Some are staffed by very large contract management companies, and these companies staff some of the big ones staff many emergency departments across a region or actually across the United States. And sometimes they will have professional conferences. Sometimes they have a more central person to assist in education, in getting into the emergency department. And the same could also be true about some hospital systems where there's multiple hospitals and a centralized emergency department or centralized emergency administration. For instance, in my system, the Sinai Health System, we have 2 hospitals, and I'm considered the system chair over both of the 2 emergency departments. So I would be the person to go to access both of the emergency departments. And that may or may not be true for other hospital systems, and so one of the things you really need to do is to get a better understanding of what the environment looks like. So that kind of leads right into the next question, which is, people say you've seen one emergency department, but so the question is, what kind of services do they provide? Are they a teaching hospital or a non-teaching hospital? Do they have problem areas that might be onto that emergency department? And I'll say that many emergency departments across the country have issues or concerns related to psychiatric patients, and especially boarding of psychiatric patients in their emergency department. And like we talked before, it would be helpful to know, are the physicians contracted to some other entity, or are they hospital employees or employees of related entities? Are they hired by a medical school? again, this will help understand how to best approach and kind of what their issues and priorities might be. One of the first things to do is to find out who runs the department, who's the nurse manager, who's the medical director, if it's an academic institution, who the chair is. And then, so once you've connected with them, then the next step is to say, hey, could I present, the SPRC tool? Could I present something about psychiatric emergencies or how we can connect or work together or whatever? And what I usually recommend, the first stage is to find out when the departmental meetings are, or section meetings are, or nurse meetings for the department, or mid-level meetings. And there may be different meetings for each different provider in a department. Or are there regional meetings that occur, or system meetings that occur that I can hook into, that I can present some of the material at? And usually they're going to be fairly time limited. So find out, what would be appropriate time-wise, what they want to hear, and what their needs are. So it's important that we build relationships. And I would say in most emergency departments across the country, there's somebody there that will be a champion for patients with psychiatric conditions, with suicidality. And so it's important to find out who that person is and go to that champion and try to get them to assist you in doing the education, collaboration, getting new treatment modalities up and running, referral patterns. All those things are really important. Usually that champion will connect you with either the medical director or the chair of the emergency department, because that person will ultimately have to approve whatever changes or processes or collaborations are being worked on. The nurse manager, of course, I think it's always important to involve nursing in any kind of care change in the emergency setting. And there's maybe different roles, as Emmy said a little while ago, for psychiatry as well as for social work. And there's different models. And so you need to find out who does the psychiatric assessment, who does the referrals, who decides if the patient's admitted or not admitted. And it varies all over the place, somewhat due to resource limitation. The rural hospitals that have little connectedness or little psychiatry resources may depend on a social worker or telepsychiatry or something else. So we need to find out what their role is and connect with them as well. Now, I threw up this slide of how to change emergency physician behavior, because we know that there are certain attitudes that they have related to psychiatric patients. It's not just the physicians, it's the nurses as well. And the other part of this is we need to find out how to get them to change the paradigm, to rethink how they treat these kind of patients. And I think, again, the SPRC tool is one good step at saying there may be another way to treat these patients or to think about them. So we look at, what I call the cowboy or cowgirl physician, and there's usually someone in the group that's the first to start or to embrace new procedures or treatments or protocols. And sometimes when one person starts it, it spreads throughout the department. Sometimes it'll come from psychiatry instead because they're thought to be the experts. But here is the rub about that. Even though it comes from psychiatry, it's important they have buy-in from the emergency department. A lot of times they'll look for something that's literature-based or evidence-based. They want to know why they should change what they're usually doing, and so we need to think about how we can persuade them, and that's kind of the next part of this talk. And do guidelines, treatment protocols, et cetera, demonstrate improved care? And I think that most of us would agree that they do. So it's important when you contact them or connect with them, that you understand that they're busy places, that whatever you present to them, it would be beneficial, that it would expedite patient care or make their job easier. And I think that, again, going back to the SPRC tool that we're going to talk in more detail about, that is the purpose, is to really assist in that evaluation process and help us, guide us. And can it reduce the number of patients boarded in the emergency department? Maybe. We don't have data yet, but there is some study going on about that, and maybe we'll have more data shortly about that. The next issue is, so they say, well, but I'm not sure about the way these guidelines have been developed or the tools been developed. And so I think it's important that we're upfront about that these are consensus guidelines. It was based on both the available research and using the RAND methodology. Now, the problem is that if asked for an evidence-based, it's hard to do good clinical studies on mental health patients that are randomized, controlled, double-blinded studies in the emergency setting, especially when you're dealing with consent issues, suicidality issues, and things like that. So this is the next best thing that we have out there, is consensus guidelines. And maybe we'll be able to convert some of that into randomized controlled trials as the process evolves. So as we think about developing the evidence, you might want to think about building evaluation into your prevention approach. I mean, at least to explain how many patients got the tool and what happened to that tool, and